Good morning. My name is Salman Keshavji, and I'm the director of the Center for Global Health Delivery, one of the hosts of this meeting, and I'm really pleased to welcome everyone from far and wide to Cambridge. Some of you from as far as a neighboring town, and some of you have come all the way from India and other places, so we're really grateful. I want to say a little bit about the meeting, but before I do, I want to note that this meeting, which I think is going to be a really important opportunity to think about universal healthcare as we're moving forward, is not only important to us and important to the medical school, it's also really important to a number of bodies at the university that have been thinking about how to better deliver healthcare. So this meeting has actually been co-sponsored by a number of people. One is the Asia Center here at Harvard, the Center for History of Medicine at Countway Medical Library, the Center for Middle Eastern Studies, the Davis Center for Russian and Eurasian Studies, the Harvard Global Health Institute, and the Middle East Initiative at the Harvard Kennedy School. So a number of people came together to really think about, how 40 years on we can, we can rethink primary healthcare and universal health coverage, and really do what we claim to want to do in academia, which is to use history and learn from it, and not redo what we did in the past. And so this meeting is the product of a group in our Department of Global Health and Social Medicine, led by Scott Podolsky, who's right there, who's the chair, and you guys have all heard from Scott, and by Aaron Shakow, who's right there. And you've probably all received emails from both of them. And we also had a few other people on the organizing committee, Megan Murray, Vikram Patel, and David Jones, who I think is here. I don't think Vikram is. David's right there. So we sat down and we thought, if we were going to be rethinking, what would it look like? And this group of people, minus one or two who unfortunately were not able to come, were the result of this. We thought, why don't we bring people from different fields of social science, but certainly historians, to tell us what was the moment like in the 1970s, when in this post-colonial moment, in this moment where you see the rise of cost effectiveness and certain types of neoliberal thinking at the World Bank and other places. What was that moment like, and and what solutions emerged from that, and how do we take that learning, which I think was rooted in ideas about human rights versus citizen rights versus people getting things because they could pay for it, ideas that people deserved a minimum of healthcare, but a debate over what was that minimum, et cetera. How do we take what took place then and really use the learning to think about what's going on right now? And so the way we've set this up is that we'll have a number of people present. As you can see, the room is round, and we really want people to interact with each other, hopefully argue about some of these things in a collegial way. And our goal isn't to litigate the past in some, but to really draw on it and think about how we can learn more. So we were going to start with an update from the UNGA meeting, the UN General Assembly meeting, and what happened with the universal healthcare debate there last month. But I think what we're going to do is we're going to rearrange the agenda a little bit and dive right into the first session, and then have our colleague who will talk about UNGA talk about it a little bit later in the day, so that it later in the morning before lunch, it can be part of our discussion. So anyway, let me thank you all for coming again. Welcome. Looking forward to a spirited and fun debate with each other. And I'm going to turn the floor over to Professor Alan Brandt, who will lead us through the morning. Alan.
Thanks, Salman. It's great to be here. I'm Alan Brandt. I'm a longtime member of the Department of Global Health and Social Medicine, nearly as long as the Alma-Ata Declaration. So that kind of puts a point on it. I joined the department when I was about 12 years old, so that explains everything. It's really great to be here. I really can't think of a more important time to both reflect on the commemoration of Alma-Ata at, as Salman said, around 40 years, and to think about where we are in terms of the fundamental questions of healthcare, of health disparities, health systems, and human rights. And there has been a sort of guiding notion in our department that Salman referred to, is that we don't really look at the present and the future without considering the past. And it's been a kind of conviction of ours from the very founding of the department. The great chairs of our department, Leon Eisenberg, who was my mentor, Arthur Kleinman, who has mentored so many people in the room, Byron Good, Jim Kim, especially Paul Farmer, who's been so dedicated to a historical orientation to thinking about the present and the future. It's been a conviction of ours that we need to do serious historical work, and that it's impossible to have a roadmap for the future without looking at the itinerary of where we've been, how we got there, where we ran into powerful obstacles and topography that we didn't always anticipate. And I think that's really at the core of today's meeting. So we've really gathered a distinguished group of people who have worked across many fields. That's been another principle of our work here at Harvard in global health, to gather as many people as we can from as many diverse fields as we can, who can help us reflect on what really needs to happen, what we need to do, and how we can do it, and how we can implement the basic principles of social justice and human rights when we think about the broad problems of health around a very complicated and difficult planet in a difficult time. So this morning, we're going to really focus on work that historians and historical thinkers have done around fundamental questions that we largely associate with the ideal of health for all. And I thought that rather than have detailed descriptions of our speakers' biographies, those are really in your folders, and I'll just introduce them briefly, but I'd like to invite the first three speakers, Julia Walsh, Michael Knipper, and the third, and Aaron Shakow. There you are. I'm looking to most of the group. I'd like to invite you to come down, and I will just briefly introduce you. This is kind of a double session, and so we have a fourth speaker that will lead off after a brief break in about an hour, and then two distinguished commentators. And I'll introduce the second part of our group after our break. So let me just say a word about Aaron. Aaron Shakow is a dear colleague and friend of mine, a historian of the Middle East. He's written extensively on bubonic plague, but he also has a deep historical sensibility about contemporary problems of health and healthcare. And he's currently the director of our initiative on healing and humanity. Michael Knipper is at the Institute for the History of Medicine at the Justus Liebig University, and it's hard for anyone who's been doing global health not to know his distinguished work. It's a pleasure to welcome you here. And Julia Walsh is Professor of International Health and Maternal and Child Health at the University of California at Berkeley School of Public Health. She's had an enormous impact on the care of women and children and our understanding of health systems and primary care, all issues that'll be central to our discussion today. So I'm so grateful to all of you for being here, and we'll start with Aaron Shakow. His talk today is called "A Double Truth Doctrine, Primary Health Care Between Empire and Emancipation. Aaron.
So usually I don't write out these talks, but about a day before you guys got here, Salman put the fear of the Lord into us by adding time to each of the speakers' lines in the agenda. So in the interests of being modestly efficient, I will read this, but I'll try and be interactive as much as possible. So, like many people on this side of the Atlantic, I've recently discovered the joys of British parliamentary Twitter. I don't have any expertise in Brexitology, but to my provincial ear as I listen, what's going on in Westminster Palace seems oddly related to our topic of discussion today. For one thing, it seems that we were wrong about the era of decolonization that was the backdrop for Alma-Ata. It didn't finish up in the 60s and 70s. The colonial era is ending now. After almost 500 years, England may finally be setting the rest of Ireland free, at least as far as tariff regimes go. And it's not the left that's leading the way. Labour Party governments have been consistent in ratifying colonialism and neoliberalism, justifying this policy as a way to level labor and living standards around the world. Instead, it seems that radical devolution was a special project of billionaires in England, America, and elsewhere, seeking to evade the application of those labor and living standards, even in Sussex, let alone in Puerto Rico. And so, if my clicker works, it doesn't. I had a great slide. Let's see if we can produce it. There's a mouse that might help. There we go. Cool. And so the Brexit that was supposed to save NHS by excluding migrants from the former territories, there's the notice of that down on the lower left. Instead, it now threatens to cut NHS's supply chain. So what I want to do here is not yank-splain British politics, but rather to highlight a paradox as we gather to contemplate the Conference on Primary Health Care at Alma-Ata, which was, one might say, NHS through a glass darkly. Post-colonial states like India, Malaysia, and Sierra Leone certainly described healthcare as a basic right of citizenship. Sierra Leone even named its government biomedical institutions the National Health Service, a parallel that was encouraged by American politicians like Roosevelt, Truman, and Kennedy. Yet, after Sierra Leone gained independence in 1961, the Labor government of Harold Wilson refused to forgive millions of pounds in debt taken out decades before by the British Colonial Office. It needed every last farthing to keep NHS solvent. And so Sierra Leone's National Health Service was a stillborn mandate, even during a decade when its economic and political growth were relatively steady. The public health implications were reported with frustration and alarm each year by the country's representatives to the World Health Assembly, and one of them, Marcella Davies, brought Alma-Ata to tears later with an emotional reading of the declaration. I don't know that any analysis has been done for anywhere in Africa, let alone Sierra Leone, like Utsa Patnaik's recently published estimate that British colonialism removed $45 trillion from India between 1765 and 1938. But even without precise figures, it's clear that the geographical imbalance of the welfare state owed much to the political economic relationship that preceded decolonization. Fred Cooper has written a lot about this. Primary health care was supposed to be part of a new international economic order. WHO described this NIEO in 1979 as a state of internationally just redress of the present imbalances between the developing and the affluent countries to be achieved by means of a series of reforms aimed at improving the lot of developing countries. But a truly meaningful NIEO would have meant something like reparations. Instead, Between the burdens of the domestic welfare state in former colonial powers and the disinterest of Western bankers in wiping anything off their ledgers, the reality was something quite different. This is even before one considers the impact in the developing world of 2 oil shocks and servicing commercial debt that had, in some cases, been assumed at the explicit recommendation of the World Bank and WHO to fund health services expansion after Alma-Ata. In light of all this, I would argue that the vision of primary health care expressed at Alma-Ata was in retrospect counter-revolutionary rather than revolutionary. It held off demands for real international social change, or at least accommodated a patronage system that was not prepared to address them. In particular, it's my contention that the failure of health for all as a spur to social change owed substantially to the incoherence of the Declaration's framing concept. References to primary health care at Alma-Ata invoked fashionable language of space-age welfarism, but in fact, they were a portmanteau, and a particularly unwieldy one. Yet the appeal to borrowed jargon from developed economies wasn't benign. On the one hand, it helped formalize a global separate but equal doctrine, according to which primary health care meant different things in different places. On the other hand, it exported to impoverished communities neoliberal ideals like human capital, consumer choice, and cost effectiveness that had become prominent in wealthy countries during the 1960s as a counterweight to health sector expansion. The strategic missteps, if that's what they were, of the global primary health care campaign offer a cautionary tale for advocates of universal health care, UHC, today. Time's short, so I'm going to be a little telegraphic, but we can maybe expand on some of this in the discussion. The main point is as follows. Stripped of superficial and often contradictory rhetoric, primary health care as described at Alma-Ata was little advance from the basic health services agenda mandated by the WHO Executive Board in 1971. This was in turn a restatement of principles that had been pursued by WHO since the early 1950s, by the League of Nations Health Organization before it, and ultimately derived from colonial institutions. And Randy Packard, whom we're very grateful to have here, has made many of these points in his recent history of global health. Moreover, in its tolerance for a sharply limited menu of health interventions, which was justified on the promise of comprehensive services later, the WHO agenda of primary health care was explicitly calling upon the colonial discourse, later embedded in international treaty law, of progressive realization. These essential continuities are why attempts to realize the Alma-Ata Declaration fell back so quickly on 3 familiar health system elements: 1 institutional, the village health center; 1 occupational, the community health worker; and 1 subjective, human capital. I'll trace this health system lineage backward in a moment, or we can again park it for the discussion. But first I want to address the origins of the terminology. Where did primary health care come from? What was the referent? In 1982, the historian of the American healthcare system, Paul Starr, described primary health care as the protagonist in a pitched battle against health sector inflation. According to this account, medical research and hospital construction after the war was unbalanced and became increasingly costly and irrational. Starr writes that what made the system unbalanced was its failure to provide for primary care. But the main problem with this story is that the concept of primary health care did not even exist for more than a decade after 1945. Bertrand Dawson in the UK did call in 1920 for the construction of primary health centers. But this health center concept failed, even in England, largely for sociological reasons. Where primary health centers appeared during this period was in Latin America, colonial Asia, and Africa. But what remains to be mentioned about this particular institution is that primary was a reference to the institution. It wasn't a reference to a kind of service or a kind of practice or a kind of care. What was actually on offer at primary health centers from Hungary to India to Chile was referred to as basic health services. The actual context in which primary healthcare arose in wealthy countries was paradoxically the sudden disappearance of the jack-of-all-trades approach to medicine after the war. As this shift became more pronounced, Kerr White, a health economist at the University of North Carolina, was awarded a brand new grant from the federal government to study hospital and medical facilities, and he began to analyze patient referrals from the shrinking contingent of general practitioners to specialists at UNC medical centers. His conclusion from this pioneering exercise in health services research was that the patient may be a more relevant primary unit of observation than the disease, the visit, or the admission. His surprising discovery was that patients were very often referring themselves rather than being referred at the point of service delivery to specialists for what he called primary continuing medical care. That's the origin of primary health care. And yet, academic medicine and public health, he complained, were having no impact on arrangements for healthcare delivery to consumers, as he said, in the United States or any other Western country. They didn't concern themselves with the substantive problems of medical care. What did they concern themselves with? They concerned themselves with the distribution of healthcare and the norms and ethics of the profession. That was his complaint. White, by contrast, was explicitly focusing on patients as consumers. Those consumers were his primary unit of observation because they were the ones who defined the primary unit of illness by arriving at the tertiary care hospital to consume its services. White dismissively referred to the social responsibilities that academic medicine was concerning itself with, instead proposing a cybernetic, demand-driven model of the healthcare system in its functional aspects that was remarkably similar to the neoclassical model of the market that was being conceptualized in those same years by neoclassical economists like Theodore Schultz, Gary Becker, Kenneth Arrow, and Salma Mushkin. White was focused on establishing a new economic discipline, primary care, using consumers as the primary unit of observation, was the epistemic field where consumption by these units took place. But despite his subsequent claims, the immediate impact of this abstract concept was somewhat secondary on the practice of caregiving. It was only after Medicare began to unify the fragmented American health system and discipline the forces that were profiting from it that primary medical care could become a thing. Some of the thing that it became was only tangentially related to White's analysis, and it was clearly the outcome of parochial interests. For example, an influential AMA, American Medical Association report in 1966 focused on supply functions rather than demand functions. A primary physician, it said, rather than a patient, was the basic unit of observation, and this individual or unit was defined as the provider of comprehensive and continuing health care. That was what was provided by the primary physician, comprehensive and continuing health care. A year into the 1970s, state health officials reported agreeing about the serious deficiency in the delivery of primary care, but also reported a complete lack of consensus about what that meant. Nobody could agree on what primary health care was. And the reason isn't hard to look for. It was a struggle over the good. In the competition for healthcare dollars, every stakeholder wanted to be primary. The health system in the United States around 1973 finally came into equilibrium, symbolized by the Health Maintenance Organization Act in 1973. At that point, the concept of primary care coalesced in the US. Now it described institutions where patients could find treatment for a comprehensive list of health issues within a comfortable travel time and with minimal inconvenience. As the first link in the referral chain, it was also designated, not coincidentally, as the pinch point for rationing of care. So let's return to Alma-Ata. In the Alma-Ata Declaration, primary health care was defined similarly, if you look at the end, as the first level of contact with the national health system, bringing health care as close as possible to where people live and work. That sounds very familiar. But PHC was also defined as essential healthcare. That's to say, a set of services which was being pitted against other services which were not essential. This was antithetical to the standard concept of primary care as it evolved in the United States and in the UK in the 1960s, which is supposed to be comprehensive. The essential services were to be made accessible, not actually provided, leaving a gaping hole in the promise of universality that's attached to that sentence. Meanwhile, the cost of these essential services must be one that the community and country can afford to maintain at every stage of their development. This clause not only embedded the inevitable double standards associated with progressive realization, about which I'll say a little bit more in a moment, it also implied an allergy to recurrent costs, which again ruled out all but the simplest procedures. It implied that the sources of revenue for PHC would be found within the boundaries of the village or neighborhood on the one hand, and the nation on the other, and not outside them. That implicit restriction became overt 9 years after Alma-Ata, when a policy of community financing was announced at the annual meeting of WHO's African Regional Committee in Bamako, Mali. It seemed to contradict the official Alma-Ata meeting report, which said that individual payment on a fee-for-service basis is not a solution, certainly not a solution that could be widely applied. But references in the declaration to the community as a key source of financing, which were couched as part of Halfdan Mahler's fashionable commitment to decentralization, had left the possibility of such payments wide open. Members of the community can contribute financial and other resources to primary health care, the report suggested in a passage on local participation. Community members were asked to contribute their own resources in cash and kind in order to develop primary health care in accordance with the program they have worked out. One of the case studies of primary care in the WHO UNICEF report on alternative approaches to basic health needs on Nigeria actually described a revolving drug fund just like the ones that were mandated at Bamako. Moreover, in WHO's elaboration of the financing issues associated with primary health care published a few months before the Alma-Ata conference, clinics at the village level were encouraged to charge small fees for drugs, and governments were charged to find new types of local institutions through which health care can be cooperatively developed with financing partly by local people themselves. They cautioned against the exploitation by governments and international donors of this local participation or self-reliance. But it was clear that if the Declaration's invitation to channel increased technical and financial support into primary care did not materialize, these small fees would become more and more central to the success of the larger enterprise. What we see then from a close reading of WHO literature from around the time of Alma-Ata is two types of incoherence. On the one hand, PHC was a hodgepodge of concepts related to health at the community level, several of which were incompatible. The vagueness and variability of WHO and UNICEF's definition of primary health care was criticized sharply by Tanzania's Eleuthero Tarimo at a meeting of the WHO Executive Board in 1977. He expressed his hope that the conference would clarify it, but as we've seen, it persisted. On the other hand, the aspects that were clear, which all related to the basic healthcare agenda that Randy teases out so beautifully, placed far too much of the burden for national health sector development on village communities, leading to a deep strategic incoherence. This feature, too, became increasingly pronounced after the 1975 joint report on alternative approaches to basic healthcare, and the villages were often left holding the bag. I would argue that both missteps resulted in significant measure from the haphazard attempt to rebrand the basic healthcare agenda as it evolved between the 1952 World Health Assembly discussions on health protection in a local area and the 1975 report on basic healthcare, where the idea of primary healthcare, as WHO defined it, was first laid out. The Alma-Ata conference report stated defensively that PHC means much more than the mere extension of basic health services. Yet its attempt to marry a model of comprehensive care to a far more limited health systems model was bound to collapse into the simpler version. It was fundamentally incompatible with a brief list of basic procedures which could be undertaken by minimally trained and often unpaid community health workers under the WHO and UNICEF Health for All banner. The collapse, however, was frequently chaotic, and because, as I said earlier, both WHO and the World Bank encouraged countries to take out commercial debt as a financing strategy for PHC, these deficiencies exacted a profound social cost. The paradox here is that although the concept of primary health care had been segregated by WHO, dissemination of the terminology nonetheless traced the globalization of health policy networks. Such networks have been explored in different ways by Kelly Lee, Marcos Cueto, Vincent Adams, and others. As an emblem of this phenomenon, I offer the brooding haircut of Ted Kennedy, architect of several unsuccessful attempts to realize what was by then a 50-year-old campaign for national health insurance in the United States. Next to him, of course, is WHO chief Halfdan Mahler. Already by the 1950s, a few years after WHO was founded, its headquarters in Geneva was filled with health economists who'd cut their teeth on attempts to scale back universal access to health care in Britain and the United States. Brian Abel Smith, a socialist, by the way, who published one of the first cost studies of NHS in 1956, played a key role in developing the austerity plank of the WHO's primary healthcare platform, which emphasized community financing and promoted cost-benefit studies and other systems analysis approaches. It was the subject of a special study group almost a year before the Alma-Ata conference, which published its report well in advance of the declaration. It's notable that in the US government's Africa strategy document of 1979, the WHO primary health care approach was endorsed specifically because it, quote, appears to be the most cost-effective means of applying US resources. Mahler had become a proponent of systems analysis as head of the organization's tuberculosis program in the 1960s. Indeed, in 1967, he went so far as to invite Martin Feldstein, a prominent American backer of rational choice theory and systems analysis in healthcare, who just completed his doctoral dissertation on NHS hospital expenditures at Oxford. He invited him to visit India and make a prescription for its tuberculosis programs. Feldstein went on to become the chairman of Ronald Reagan's Council of Economic Advisors and G.W. Bush's point person on Social Security privatization. His analysis was published by WHO shortly after Mahler's appointment as Director General in 1973, and it contributed to a notably austerity-minded revision of the organization's TB policy of a year later. The significance of these professional and intellectual associations is plain to see when one examines the proceedings of the WHO Executive Board, which very often included high-ranking health officials from developed countries, if not the ministers themselves. WHO dues and extraordinary contributions were very commonly a line item in national health budgets, creating the perception, if not the reality, of a zero sum. During the 1950s, for example, as Canada and Australia embarked on a dramatic expansion of their health systems, their board members intervened repeatedly to limit WHO spending on its tuberculosis program. I've already mentioned the less direct but still suggestive coincidence of NHS expansion in the 60s and the offloading of colonial-era debt obligations by the Wilson government. This was a moment when NHS had developed a mania for cost-benefit analysis, in part because the system's annual cost quickly proved to be more than 3 times larger than the £95 million that had been originally estimated for England and Wales in 1946. The real danger to the social services, claimed the Chancellor of the Exchequer in 1952, comes from the risk of bankruptcy. And so I return to my earlier observation. Because the fundamental financial injustices of the colonial era were never addressed, the deeply intertwined nature of global health policy and financing meant that poor countries had a line item in a budget battle they could never win. Without a secure internal tax base, with debt obligations swollen by late colonial expenditures, their national health services would always be basic and never primary, a reality which quickly became clear during the aftermath of the WHO-UNICEF primary healthcare campaign. So in the title of this talk, I called primary healthcare at Alma-Ata a double truth doctrine, which is a reference to a medieval philosophical tradition that used esoteric language in a way that the masses were to read one way and the initiates were to read another. There was a very dramatic rejection of this in the 18th century by Condorcet, who called it anti-democratic and thought that in democratic discourse it was unacceptable. Indeed, it is. The question of why Mahler, Newell, and their colleagues adopted such a disparate definition of primary care is well worth further archival research. On first glance, it seems plausible that the jargon was originally borrowed because it allowed advocates of healthcare expansion in the developing world to leverage existing budget allocations for primary healthcare in donor countries from people like Ted Kennedy. But there's also a darker reading. Ambiguity allowed officials to promote half measures and austerity budgets as instruments of liberation. This gets to a question Salman asked me yesterday. Was Mahler a neoliberal, or was he well-meaning? As I understood the question he was asking, was Mahler trying to upend the state-based system of healthcare in favor of an unregulated world market, or was he trying to preserve the state system in very inimical circumstances? So I'd like to respond now. I was thinking about it over the last day or so, by offering another definition of neoliberal, as if we don't have enough. Somebody who tolerates a double truth doctrine, somebody who lays claim to egalitarian principles, but is tolerant of those principles being applied different ways in different places. Or, as we call it in our work on global tuberculosis policy, a double standard. This neoliberal double truth doctrine is in many ways an explicit continuation of colonial policy. I think Ole Norheim is going to talk about progressive realization after lunch, but I'd like to foreshadow that discussion by pointing out that one of the most prominent uses of this term before the post-World War II period, when it became a kind of liberal byword, was in the Montague Declaration of 1917, which stated that British policy in India was progressive realization of a limited national autonomy, or, if you will, basic sovereignty, not comprehensive primary sovereignty. Because of WHO and UNICEF's double truth doctrine, primary healthcare was selective from its very inception. Can the concept be recovered? Perhaps. Many dedicated practitioners, many of them in this room and around the world, courageously attempt to do so every day. Yet PHC is now freighted with decades of disparate treatment, and advocates of global health equity may be better served by abandoning the concept entirely and focusing instead on the specifics of universal and comprehensive healthcare on the one hand, and clear-eyed political strategies for overturning the structures of power that prevent its realization on the other. Whether the same calculation also applies to the current campaign for UHC remains to be seen. Thank you.
Thanks, Aaron. We're off to a very excellent start. I'd like to invite Michael Knipper to come up now. Please jot down your questions for Aaron, because I'm eager to take questions, but I'm also mindful of the time. So, Michael's talk is Equity, Selective Healthcare, and Current Relevance. Oh, no, that's Julia's talk. It's Alma-Ata, 1978, An Unfinished Revolution in the History of Global Health. Thank you.
Thank you, Alan. And also Aaron for this very interesting thoughts and provocative points. I will go in a little different direction, but first of all, I do want to thank and congratulate the organizers, Scott and all the others, for hosting this conference, and to express my gratitude for actually inviting me, but also for encouraging us to reflect about this notion of health for all again, and about the ideas, the values, the concepts related to this notion, and also the experiences, the politics, the economic impact, and so on that I mentioned. So I think there's a lot of misunderstandings, multiple understandings of what health for all, what primary healthcare means, and I will be happy to try to give some thoughts about
this, and I'm especially fortunate. I feel especially fortunate to be invited here to share some thoughts about Alma-Ata and primary healthcare, because it was actually what drove me into medical history, medical anthropology, and global health. I first met the notion of primary healthcare when I was volunteering as a medical student, first in the early 90s in Ecuador, in the Amazon, in a primary healthcare project. And I was absolutely fascinated, I have to say, and I'm still fascinated by Alma-Ata and the primary healthcare idea and movement. But I was fascinated by the idea that physicians were living in the rural area, that they were collaborating in the communities, that the community had a strong, at least in theory and sometimes in practice, a strong ownership of the project, even though I already then saw some kind of contradictions. And that medicine and healthcare could be thought differently than what I learned at med school. It was only technical, only clinical, only hospital based. And that it also addresses kind of what you now say the social determinants or the larger determinants of health. And the most striking experience for me was to learn that, for example, the local primary healthcare project invited a geographer, a topographer, to do the kind of cartography as a basis for assuring the indigenous communities their land rights, because it was seen that without the right to their land, the indigenous people could not survive, could not have a decent livelihood. And so the process of guaranteeing land rights for the indigenous communities in this region and the region in the Amazon from Ecuador was really inspired by the health activists, by physicians inviting and funding the person who did the maps, and then starting the process of defining the land, the borders, and the land rights. And these community rights to their land are still existing until today. And I found, well, that's an interesting example that a topographer was invited for a health project. This is a different way of understanding health and activities in health than I learned it at med school, actually, and that was kind of probably the first and most fascinating entrance for me into this point. At the same time, I was asking myself, what does this mean for primary healthcare? What does primary healthcare actually mean when there also are topographers involved? And I tried to look a little bit more closer to the history of primary healthcare, especially from the perspective of the medical history, of the history of social medicine, and relating the discussions about Alma-Ata and so on, and the experiences with a larger question for a social medicine of health or history of social medicine. So, and my main question is actually, what is really the essence of primary healthcare from a health point of view, and what does the now 41-year-old Alma-Ata Declaration really mean for global health today and also for the future? So I will now look a little bit more systematically into these questions, based mainly on my reading of publications and unpublished sources related to Alma-Ata from the 70s and 80s, and on historical literature. So it's Marcos Cueto, Socrates Litsios, I'm very happy seeing you here, that informed this to a large extent, and Reynold Packard also, absolutely. And some oral histories, conversation with some of the actors involved, or individuals involved in the Alma-Ata process, and it was mainly one woman, Inga Brüggemann. She's not really well known, but she entered the WHO in 1966 as a sociologist and literature scientist, and was really part of the closest team working together with Halfdan Mahler, and she shared with me many memories and also documents from the internal processes. And so what I try to attempt is a little bit an absolutely unfinished historical understanding of primary healthcare, but from health interested from a medical point of view, with the economic dimensions are of true importance, but I think there's also this dimension. So the first point would be, what is the definition of primary healthcare? I think that's the major challenge. You mentioned it already, to have a concise definition according to the Alma-Ata Declaration. I have come to the point so that it's probably impossible to have a real concise definition, because there are multiple ways to understand primary health care, just because also the declaration itself, as you mentioned before, is contradictory and not really coherent. You also already showed this number 6 of the Alma Declaration, and number 7, here it says essential healthcare, but here it goes on with the principles, which are that it has to be locally embedded and so on, which is all much more the value part, the intersectoral the part we could also today relate to social determinants of health. It's also the issue of finding local solutions for these general problems. So it's kind of a direct contradiction, I think, in the same document, and that offers multiple readings. And considering the multiplicity of people, voices, backgrounds in the primary healthcare, in the global health community, there are physicians, there are economists, there are anthropologists, there are public health people with different backgrounds, experiences. There are people like Marla and his colleagues who have made their career in so-called developing countries, other living only in countries of the north. So it's absolutely no surprise that there are all these different understandings. On the other hand, I think it's possible to identify some corner points what primary health care at the end means. And for me, I think I will not give any more. I don't think that there's one definition, but I try to understand Alma-Ata in '78 and the history before and after as a historical process of a deep and not necessarily coherent reflection of of multiple actors in and related to WHO regarding the question of how best to achieve health for all in the 1970s and 80s. So the declaration of Alma-Ata in this perspective is only a materialized yet a still intermediate result of a larger process that did not start and end in Geneva, Alma-Ata or Bellagio in the late 1970s or early 1980s. Moreover, I understand this process as ongoing until today, including this conference and also, and very important, these events to commemorate Alma-Ata every 10 years, starting in Riga in 1988, and now the last version was in Astana 1 year ago, where we always find new interpretations according to the time and context of what primary healthcare means. And so we are in a very large reflection process, and that's for me the most productive way to understand, and not to look for the one definition, for the one and only way of understanding it. But these reflections are related towards some principles or some basic points which are related to the nature of health and medicine and doing health and medicine, which is kind of a historical evidence we have of the conditions that are relevant for doing health and achieving health for all, probably. And these central features are the first one is, I think, the looking on the central features, also to look on the origin, and that was one of my points from today. And I think the starting point for this reflection in the Alma-Ata process, which is also known from before, but and today, is really the consideration of these existing gross inequalities in the health status of people, particularly between developed and developing countries, which is a second point of the Alma-Ata Declaration, as well as within countries, that this is politically, socially, economically unacceptable. So this moral statement that health inequalities are unacceptable, and there I think, regarding the question if Marlowe and his colleagues have been well-minded or kind of agents of neoliberalism, I still think that was kind of well-minded people, but we never know. We cannot look into the heads of these people. But I think this consideration is kind of a core that reflects the basic motivation behind the Alma-Ata process and relates to a larger debate since the 1960s about the failure of the, at that time, conventional ways of international health intervention. Those technically defined vertical approaches to tackle specific diseases like malaria, tuberculosis, etc., and which were known to leave many rural populations behind in the terminology of the the sustainable development goals from today. So it was about to address, like Mahler said in his opening speech in Alma-Ata, that the existing gap between the health haves and the no haves or health no haves must be closed. And there have been already, and you mentioned it already before, many discussions of basic health service. So it's all well known, but I think there was a different momentum in the Alma-Ata process related to this profound reflection of people like Marla Newell and others. And for me, the highlights are probably, or the examples are, for example, the Makerere conference in Uganda, where it was already about rural health in the development world and showing that the failure of the conventional approach. And then it was this study you mentioned already also about alternative approaches uh, by WHO, managed by Kent Newell, that ended up in the book Health by the People, that also looked for really alternatives to the conventional, thinking what have we done before, what do we have to change? And that included, for example, the community orientation, it included the collaboration with local knowledge, with traditional medicines, and so on. There were some relevant new ideas that were not at all true, at all new, but they were kind of condensed in this process from the 17th, I think. And the question for the revolution in global health, I will only focus shortly on 3 points that I find relevant. I will not go on the struggle between comprehensive and selective, which is well known from the history, and more look on 3 other points. First, the first is on values and priorities. The references to health as a human right and are in Alma-Ata still rather vague. So when you look into the documents, there's only a very vague notion and no relation and no reference actually to the international law at that time. So no reference to the 1966 Covenant on Social, Economic and Cultural Rights with the human right to health already legally defined. It's kind of a notion, and Inga Brüggemann told me, well, we took this notion of health as a human right as kind of convenient without really knowing what it meant. And that's an interesting point. And there's a kind of a health and a health triggered idea of health for all and health as a human right. And then values and priority, and then the point was really to stress, and that's very strong in the document in Alma-Ata, but also in the later documents from 1988 in Riga, for example, the commitment to overcome these health inequalities, and it resonates a little bit what now in this sustainable development rhetoric is meant by no one is left behind. Really to go for those first behind, to have really kind of a priority on those who are farthest behind and most difficult to reach. So this very strong equity impulse. And then regarding health system, primary health care at that times was really an attempt, I think, to invert the priorities of healthcare, to organize the whole health system according to the goal of supporting primary care and the population most in need. The university professor or the clinician or the health manager would have to be primarily committed to supporting health workers in the villages and underserved communities, really kind of a revolutionary approach, and to address determinants of health and not look only on the clinical part. So that's kind of, I think, really demanding for the conventional understanding of health. And then there's the point of terminology. I was talking to Ilana Kickbusch. I don't know if you know this name. She is professor for global health in Geneva, the Graduate Institute, and one of the big figures in Europe for global health. And I was talking with her about primary healthcare, and she was leading the Ottawa process for the Ottawa Charter on Health Prevention. She said to me it was probably an error to call it, and you mentioned also the question of terminology, to say primary health care, because this suggests it is about health care, access to care like universal health coverage, and kind of omits the other dimension, which is determinants, values, social development, intersectorality, and so on. So with offering this notion of primary health care that relates very much to further discussions about basic health services and so on, it already distorted a little bit, in her opinion, the perspective, especially regarding health prevention and others. So it was not really well done to give this name primary health care and not think about probably another one. And then the last point is the vagueness. You already mentioned it's one of the huge critiques that we hear about primary healthcare. It's too vague, it cannot be applied easily. So I think that the vagueness of the declaration which has always been identified as one of the biggest flaws of Alma-Ata version of primary healthcare, is probably one of its strengths. So, in his opening speech to Alma-Ata in Alma-Ata in 1978, Mahler, for example, explained as his motto that the guiding principle for private healthcare should be don't adopt, adapt. So that you don't go to adopt anything, but to adapt certain ideas, goals, and principles to the local concept and their context. And there's evidence that one of the key authors of the declaration, Dr. Joshua Cohn, a close collaborator of Mahler in his years at WHO, deliberately kept the recommendations open and rather vague, indicating topics, values, and goals to consider instead of concrete technical advice ready to be applied. Yet this approach demands of health professionals to take time and efforts for seriously engaging with communities and to focus on the social and structural dimension of health in any given place for finding a locally feasible solution. It demands time, it demands humility, it demands what we would today call cultural competency, structural competency, and so on. And that's really kind of a revolutionary idea, especially reconsidering how medical education and medical institutions are functioning. And it demands probably what we today would be call, I would like to call an ethnographic perspective, really go and engage locally and to contextualize health. And our medicine, medical systems, and medical education and research is mainly directed to decontextualize health knowledge. And the issue of contextualizing is really demanding and something new. And that's for me one of the basic points of primary healthcare, which also relates to current discussions. And I'm coming to my conclusions now, asking a little bit for primary healthcare 4.0, because we have now the fourth version of remembering Alma-Ata, what can be the current version. And I think, and we know the discussions of universal health coverage being probably the new version, but I think independent of the label, actually, we have to ask three basic questions, I think. Values, we have to think about global topics and local realities, so to go local, and to see global health as a social movement, just as Alma-Ata also was seen, or primary healthcare, as a social movement by people like Mahler, Brandt, and others. So, values. I think we need a clear, coherent, and consistent commitment to health equity and the human right to health, according to what we now have both in international law. We are much more advanced than in the 60s and 70s, both in the legal as well as in the conceptual and health-related concepts regarding applying health right-based approaches to health. The critical question is always if approaches and concepts really are meant to address really all. So if we really have the universal approach, or only say universal and then leave somebody behind. I'm very much working since 50 years in the field of migrant health, and we see that in all the attempts now for universal health coverage, migrants are left out. There's no mention. I've been in WHO in a meeting early in February with colleagues for a global health action plan on migration and health, and it was actually very difficult to convince not WHO people, but the governments of including migrants into universal health coverage concepts. So these are now the people who are left behind. And for me today, it would be the question, if migrants are included, is kind of the litmus test for equity approaches, and if the human rights approach and universal attempts are really included. And not understanding the human right to health only on the level of access to healthcare, but also determinants of health, the underlying determinants of health as they are described in the general comment from the year 2000. And then the need to go local. So the ethnographic part, and I see very encouraging examples for health and health projects going local. One is really developed by the center we are hosted here today, the Zero TB Cities initiative, where you follow the issue of TB eradication in collaboration with cities, with local units, because the national unit is too high. So you have to go local, create local networks, and work with local partners. We see this in other projects like diabetes. Cities change diabetes. We have the Healthy Cities Network. So we have in many fields of global health now this approach to go local, to work with cities, with communities, instead of the nationwide process. I think that's very much related to the idea of primary healthcare, and also to use ethnography as kind of a research tool to do implementation research to see if really the global ideas and concepts can be contextualized and make sense locally. And Cesar Abadia just published a very interesting article about universal health coverage and ethnographic research of how to understand what is going on the ground and if really the goals are met. And finally, global health as a social movement, that alludes a little bit to Mahler's approach to identify Alma-Ata and primary healthcare as a social movement. And I think today in the political landscape of today, you mentioned Brexit, you have here kind of a president that some people still don't want to mention the name as a president, and I can understand this. And yes, and from my experience with migration and health, so we have really a toxic political environment where I think that academia, civil society have really a task to bring them in and to talk about what are the determinants and the preconditions of health, and not only focusing on access to healthcare, which would for me also one demand in current discussions about primary healthcare 4.0. Thank you so much.
Thank you. Thanks, Michael. Please jot down your questions because these are such rich talks and I want you to have a chance to ask about them. Our next speaker is Julia Walsh. She'll be speaking about equity, selective primary health care, and its current relevance. Thanks, Julia.
Great. Thank you again to the organizers of the meeting, Salman and others, Scott Podolsky, for inviting me. It's a great opportunity to discuss some of these important issues of primary health care 40 years ago, and certainly its relevance to universal health coverage nowadays. I'm apologize in advance that I am going to be making your coffee break a little later because it's now, now 10 after 10 and the coffee break is supposed to. Okay, so, thank you all for listening. So the main points of my talk are going to be that health services, service coverage, and health has dramatically improved. Just extraordinary improvements in health globally. And I have a couple of graphs on that. But there remain these very sharp health inequities. Something that if we are able to achieve universal health coverage, these will be resolved. The sustainable health, the development goals are also supposed to resolve these health inequities and economic inequities. But there's but there's very limited resources that are available for achieving all of the goals of universal health coverage. So and substantial resources are required. There's a high risk of capture of many of these health reforms and these big investments that are already beginning to start in some countries to achieve universal health coverage, that they will be captured by the elites. And so many of these inequities may remain. So I suggest, very similar to what I suggested many years ago, that at least in the interim, before we achieve that, to think very seriously about, for the poorest, prioritizing the most cost-effective community interventions for the poor. But I think in addition, what we have not prioritized is and we now with the technological advances have many more opportunities, but to prioritize strong information systems, continuous monitoring systems, strengthening the management so that there can be rapid response to these so that we can know, are we actually reaching all of these poor with at least a limited package of services? That's yes. So the Alma-Ata Declaration, this is the definition of the Alma-Ata Declaration that we took in our paper 40 years ago. Again, a very different group of statements and words, phrases, than those mentioned by Aaron and by Michael. But that it includes education for health problems, promotion of food supply and nutrition, water and sanitation, maternal and child health, including family planning, immunization, prevention and control of locally endemic diseases, appropriate treatment of common diseases and injuries. That covers an enormous number of diseases, and provision of essential drugs. But back in 1978, when I wrote this paper with Kenneth Warren, who is now no longer with us, we looked at that and said, well, the Alma-Ata goals are laudable, but much too costly for most countries to provide all of these to everyone. So what you have to do is begin to look at what causes deaths around the world. And we came up with by collecting data from a number of other analyses and doing some of our own analyses, what are the major causes of death and illness around, particularly in the poorer countries. And these were multiple and complex. And it's important to then know what the major causes are. And then you want to also understand how to treat and prevent these diseases. And these can be specific to each cause. And then you need an evaluation of what works, looking at what treatment and what prevention is most efficacious and effective, and then look at costs and cost effectiveness and set priorities based upon mortality, feasibility, and cost effectiveness. So back in 1978 and 79, we came up with a very limited group of priorities, and said these should be provided to everyone, at least these small number of interventions to everyone: vaccines, oral rehydration, malaria control, breastfeeding, and in regional priorities where there's schistosomiasis, mass chemotherapy. But equity was a very important part of what our goals were. And by about a year later, not even a year later, a few months later, with a new executive director at UNICEF, Jim Grant, who had been born and lived in India, and he brought together a number of experts in the field, and they decided that UNICEF would change its orientation from its prior orientation of really concentrating on children who were refugees to concentrating on the universal child survival emergency. And his group of, he and others identified where they would concentrate on growth monitoring, oral rehydration, breastfeeding, and immunization, and then later expanded this to family planning, food, female education, and their current priorities are in a number of maternal and child health interventions. A couple of years later, United States Agency for International Development, by 1982, declared that they were going to have an additional funding of $100 million, which has subsequently risen to over $500 million, and they were going to put it into child survival and a child survival initiative. And how they were able to sell this to Congress, you could say, the people at USAID, by saying that, because Congress was extremely concerned about our financial assistance in health, where's the impact? What are we doing with all this money? And so they said, well, if this child survival initiative, we can quantify how many lives are going to be saved. And we will tell you every year and report. But we will concentrate on vaccines, oral rehydration, and malaria control. So what you can see is that the paper that Ken Warren and I wrote really inflamed this discussion and controversy about vertical programs versus horizontal programs, technocratic-based programs versus community priorities, the role of donors, the role of governments in setting priorities. And this is a discussion that began, I think, long ago, but then really moved to the fore after the publication of our paper on selective primary health care. But you can also say that there's also great evidence that both USAID and UNICEF and WHO with its expanded program on immunization, they did a lot and put in a lot of resources in funding community health worker programs for outreach. They increased the coverage of health services. They strengthened primary health care systems, particularly in management, logistics, cold chain, surveillance, information systems, supervision training. They built public and private relationships for advancing health and influenced global and country practice and policy, in addition to being able to quantify the number of lives that they were saved. So USAID has continued its 30 years, for more than 30 years, its child survival program, adding as technology has developed an increasing number of interventions around maternal and child health care. UNICEF has done the same. Yes. A counter movement that was occurring in the 1980s and 90s was primarily based in Latin America. And that was the expansion of social health insurance in many of the countries of Latin America. Mexico, Colombia was involved in several of these, where they, rather than, they had some vertical programs for things like vaccines, but then they complemented and expanded their employer-based health insurance with the expansion of public health facilities for the poor. And so the primary health care there was in facilities-based primarily, and then with outreach to the communities with community health workers. By the end of the beginning of the 1990s, to go through the history, then the landmark 1993 World Development Report in Health came out, which did a much more detailed quantification of the causes of death and globally in countries. And and what the other thing that they did is they ranked cost effectiveness of interventions. And this was much of this as what became the basis for the development of the Institute of Health Metrics and Evaluation, and that started here at Harvard and now has subsequently moved to Seattle. They made the very important point that health is important in economic development. And if you invest in health, you will also see economic growth. Since then, there has been much more in the way of research and results on that. So that the World Bank, their health investments, they rose to greater than $200 million per year back in the 90s and has subsequently increased substantially since then. So their public health practice, to look at what their priorities were. Well, first, of course, was the expanded program on immunization, adding with it a larger number of vaccines and vitamin A supplementation. School health was listed as a priority, something that where did that go? Family planning, nutrition, health information, and other public health interventions, tobacco and alcohol control, AIDS prevention, because at that time, we really did not have good treatment for AIDS. And they had estimated that this would, the public health package would avert about 8% of the burden in low and middle income, and 4% in middle income countries. Then they had a clinical services package that would be based in facilities, which was where it was tuberculosis, management of the sick child, prenatal and delivery care, family planning, treatment of sexually transmitted diseases, also affect HIV, some prevention, and limited care, which they said was just treatment and minor trauma. And they estimated that this would cost in low-income countries about $12 per capita, in middle-income countries about $21 per capita, and as you can see, it would invert a substantial proportion of the burden of disease. Shortly after that, so as we're going quickly through the history, came the Millennial Development Goals. They began to be discussed in 1995, or in the mid-1990s, were instituted and passed by hundreds of countries around the world by the Millennium Development Goals 2000 to be achieved by 2015. And the 4 health-related goals are, reducing child mortality, improving maternal health, combating HIV and AIDS, malaria and other diseases. They also promoted gender equality, empowering women, universal primary education, environmental sustainability, global partnership, and certainly eradicating extreme poverty and hunger. So again, a small number of interventions, but the idea, again, this would be of equity and the great importance of getting it out to everyone who could benefit. So let us all congratulate the global health community that because of this implementation of primary health care, selective primary health care, and the great economic growth around the world, and the extraordinary success in decreasing the number of under 5 and child deaths around the world. Even though the number of births in the world has increased since the 1990s up to 2017, the number of child deaths has gone down from over 12 million to now about under 8 million. So halved. So it's the extraordinary success. And your life expectancy has, if you go, this starts back in 1960s. It's increased from the mid 52 or 53. Now it's over 70. So extraordinary achievements. And it's important for all of us to remember that. But looking at looking at this, it hides extraordinary inequalities. If we continue the chronology, I would say it was only about, certainly in 2008, WHO did a much better job with its definition of primary health care and defined primary health care as basic inpatient care, skilled childbirth, outpatient care, community health care, and family care at home. So community health workers have always been a very important part of this. So they, again, inequities absolutely have narrowed, but gaps remain. And what's of interest is that as we have learned over time, is if you wish to narrow the gaps in inequalities, particularly among the poor, the interventions that are delivered in institutions are less equitable than those the interventions that are delivered by community health workers. So the simpler ones, the more basic, because it is more difficult for the marginalized populations to get to facilities, and I think also for facilities to maintain quality of care. The care there has been less equitable to date, but that can be improved. So as you can see, this follows a coverage index, national coverage index has improved from 20 to 2015. This is part of the countdown for the Millennial Development Goals. The richest has improved their coverage of these basic indicators. These all derive from the Demographic and Health Service surveys and also from the UNICEF surveys. They have, among the poorest, the gaps and the coverage has increased, but the gaps still remain between. And then, as you can see, absolute inequality has declined over the past 15 years, relative inequality much less. So in order to get rid of some of these inequalities, they, just in the past 2015, there was the declaration of the Sustainable Development Goals, an array of 17 different goals in order to get rid of extreme poverty and improve well-being around the world. And number 3 is the good health and well-being. I'm going to quickly go through what are the Sustainable Development Goal 3 to ensure healthy lives and promote well-being, what we said that we would accomplish by 2030. Maternal mortality declines, neonatal and child mortality declines, ending epidemics, decreasing premature mortality from non-communicable diseases, decreasing substance abuse, traffic accidents, universal access to reproductive health services, including family planning, universal coverage. This is where most of the focus and the focus of today's conference is, and tomorrow's is about. Reducing deaths from pollution, strengthening tobacco control, supporting research and development, health worker financing, and early warning and risk reduction. An extraordinary array of goals. Again, can we accomplish all that in the next 11 years? Well, then let's just look at universal health coverage. So it's the access to high-quality essential health services. And key is the second one, financial risk protection. So providing these services, high-quality services, essential health services, with free, so that, or essentially free, so that people are no longer becoming impoverished from out-of-pocket expenditures. Essential medicines, public health services, and treatment, rehabilitation, palliative care. So this is this is doing the heavy lifting, the universal health care, to try to achieve the Sustainable Development Goal 3. It's a huge agenda. Is this possible? Well, let's look at the estimates by WHO to what is it to achieve the additional investments to achieve the Sustainable Development Goals. An increase in from here we're now at 2019, about here. And are we seeing this increase in resources? We don't know. But you need up to $371 billion in new resources around the world to go into healthcare. This is expected that it's about $74 per person in low-income countries. It will mean that the GDP per capita going to health from these low-income countries would rise from 5.5% to over 7.5% of GDP. And it would be primarily from tax-based funding. So this is, yes, it's expected that there will be economic growth as a result of these improvements in health. But in order to provide these for free, you really need tax-based fundings from government budgets. So it's a huge expectation on the part of governments to increase their funding for this. What's interesting is they have a health information systems line here, but I'm having trouble finding it here. And I think that health information systems is as underrated as in its importance. I think it should be, it's extremely important if we're going to get this managed and get much of the work done to actually try to achieve better equity. So where are countries currently? Well, this is an assessment that was done by the World Bank and published last year, looking at 46 African countries and what do they charge in the way of user fees right now. If you look at particularly the low income, look at the red. So 3/4 of the low income African countries charge user fees at all levels. 2/3 of the low middle income countries in Africa charge user fees at all levels. Only when you get to the high middle income countries in Africa do you get only a small proportion charging fees. So, and this was as of a few years ago. So this is going to require substantial change in getting rid of fees in order to provide financial risk protection. And what were in these basic packages from this same analysis by the World Bank from 46 African countries? What were in their basic packages? Ooh, you really can't read this. This is, the services that were provided free were immunization, TB, and AIDS treatments, primarily funded through, as you might understand, a large amount of this comes from donor funding, from external funding. So they were provided free. And for 2/3 of them, this is bed nets and malaria, you get about 2/3 are provided free, and also antenatal care and childhood pneumonia care. So at least there are some services, and very important services, that are saving lives that are provided for free. And next one is C-sections and normal deliveries. More than 50% countries are providing them for free. Among here in this group is other treatment for other things. And as you can see, most of those are not provided for free and require payment. We can't depend upon increases in development assistance, something that you all know. So providing this universal health coverage is going to have to come from countries' tax-based budgeting systems. This is a chart of development assistance over the years, and the notable, since about 2010 or 2011, it's been pretty flat. So governments are investing in universal health coverage. And they are developing national health benefit packages of essential health services. And how do we prevent then these just to be concentrated, for example, only in cities, so that they can be, so that the middle class and the elites can have free care? So, when most of these countries, when they come up with a health benefit package, they come up where they promise more than they can deliver, so they end up rationing, which means you have care in some places and not in others, so the universal health care. Some of the most cost-effective interventions may not reach all. So what I'm suggesting is an interim solution until we can rev up more interventions, rev up more in the way of resources, provision of a smaller package of high priority service, but focus on outreach for all, so improving equity. We now know that some of these basic services are the most important for improving equity. Again, but also with a strong information system. So where resources are few, examples are what you might expect, mostly maternal and child health with tuberculosis and malaria. I would also suggest that we think about when some of these programs, such as Oportunidades and Bolsa Familia, that have been instituted in a number of different countries, where, again, they have conditional cash transfers, but for a very small package of very basic health services, and then they based on community outreach. They all have very strong, and one of the reasons they've been successful, strong systems of evaluation and monitoring as a key to transparency and accountability. But in addition to health, they also have access to nutrition and health services. So we do have, there's been a lot written on monitoring of universal health coverage through household surveys. Most of these household surveys that we depend upon are those that are DHS that really only at this point monitor maternal and child health services. And don't really monitor, have they don't really have measures of equity or financial risk protection. But so I'm urging that we look at innovative methods for monitoring. We're monitoring some of these, at least a small package of priority services that in ways that are, for example, vital registration of births and deaths are being pushed by the Bloomberg Initiative and others. We could have cluster and recapture surveys around them, biomarker tracking programs and mobile phone tracking, and using that information for rapid accountability and management, better management, and making sure that we are reaching all who could benefit from services. So in conclusion, the relevance of selective primary health care to universal coverage is that I would suggest is that we again, as an interim solution, we provide a smaller package of cost-effective community-based services to all, and making sure that that is all to all, and while establishing a robust, innovative information systems for monitoring and ensuring coverage and improving management. So thank you very much, and these are some acknowledgments for people who I've been able to discuss this with. Thanks for inviting me.